A very good NEET exam, and most of your anesthesia questions were expected from the expected topics, and I know all of you must have done great. So let us discuss what were the questions from anesthesia. These time there were quite a number of questions. I got 9-10 questions, and I would discuss all those 9 questions with you. So the first question which I got from the students are that this image was given, and during resuscitation of an unresponsive patient, in which condition we make a recovery position. So in unresponsive person, when the victim is put in recovery position. So if a victim is put in the recovery position, what does it indicate when this would have happened? So whenever we get an unconscious or unresponsive person, after making the scene safe and calling for help, we assess the pulse and breathing, and our further management depends upon the presence or absence of pulse and breathing. If both are present, the patient is not in cardiac arrest or nor in respiratory arrest. In that case, we just have to prevent any aspiration to happen, and we make this recovery position. This position prevents aspiration. So we will make this position when both pulse and breathing is present. So pulse and breathing present, we make this position. If the victim has pulse but no breathing, then this is respiratory arrest. In that case, what we do? We just give rescue breath. So pulse present, breathing absent, we just give rescue breath, right? We don't do the chest compression. And if both are absent, then it's cardiac arrest. Then we do chest compression, that is CPR, CPCR. And pulse present, absent, and breathing present is kind of not possible scenario. So remember, when both pulse and breathing is present, we make the person in recovery position. If you see this flow chart, I have so many times told you this BLS flow chart is very important. Each and every point of this is important. So whenever we get an unresponsive victim, we do the scene safety. We activate the emergency. And then we look for pulse and breathing. Within 10 seconds, we have to see whether pulse and breathing is present or not. If both pulse and breathing is normal, we make the person in recovery position to prevent aspiration. Okay. If both pulse is present, breathing is absent. So no normal breathing, but pulse is present. In that case, it is the respiratory arrest, and in respiratory arrest, we only have to give rescue breath, and every 2 minutes we have to again feel for pulse. If both pulse and breathing is not present, pulse absent, breathing absent, then it is cardiac arrest, and in cardiac arrest, we do CPR, high quality chest compression. Now remember, we go on doing this CPR in cardiac arrest till the help comes. We have already called the help, and when the help comes, it comes with automated external defibrillator, AED device. We attach the AED device, and further management depends upon the command given by AED device. That is, the AED device detects the rhythm of the heart and tell us it is shockable rhythm of cardiac arrest or non-shockable. If it is a shockable rhythm of cardiac arrest, we give shock and then resume compression ventilation. If it is non-shockable rhythm, we just do compression and ventilation. We don't give any shock. So remember this, that both pulse and breathing present, we just make the victim in recovery position. If both absent, we do a high quality chest compression, that we do a CPR because it's a cardiac arrest. If pulse is present, breathing is absent, then it's a respiratory arrest. We just give the rescue breath. Got it? Now coming on the next question. An image-based question was asked. They gave this image and asked us to identify the procedure being done in the image. So as we can see, there is a tourniquet which is tied, tourniquet tied. There are 2 tourniquet actually tied. Then IV cannula has been taken, and through that IV cannula, 0.5% lidocaine is being given to the patient. This is IVRA, intravenous regional anesthesia, or we call it Bayer's block. IVRA, or we call it Bayer's block, because this was given by Dr. August Bayer. This technique of regional anesthesia was given by Dr. August Bayer. So the answer is A, it is Bayer's block. Now remember, what is this IVRA? This is very favorite question of an exam. Intravenous regional anesthesia. That is Bayer's block. In this, we tie tourniquet and cut that particular limb from rest of the circulation, and then we give local anesthetic intravenously, but it remains in this limb itself and anesthetize all the nerve fiber of this limb. So this is what is IVRA, which is also called Bayer's block, because it was given by Dr. August Bayer. Now, two very important questions which can be asked with IVRA. Most common local anesthetic used for IVRA, that is lignocaine. So lignocaine is the most common LA which is we use for IVRA. It is used in 0.5%. And the LA which is contraindicated, local anesthetic contraindicated for IVRA, is your bupivacaine. Now bupivacaine is most cardiotoxic LA. So since it is most cardiotoxic, we cannot dare to give it even after tying tourniquet, because there is always a risk if something happens to the tourniquet, the drug can go in the systemic circulation. So risk of systemic toxicity cannot be ruled out. So we try to avoid giving bupivacaine. It's contraindicated for IVRA. Remember this. So these are two additional points I told about IVRA. Now coming on the third question. A 20-year-old patient was undergoing strabismus surgery under GA. During the procedure, patient suddenly developed rise in temperature, hypothermia, rise in carbon dioxide, hypercarbia, and muscle rigidity. Which of the following drug is most likely implicated in this condition? So patient developed hyperthermia, hypercarbia, right, and muscle rigidity. Now, these three clinical features, intra-op under anesthesia, when it develops, one of the most important DD which comes in our mind is malignant hyperthermia. And in the question, it has been asked, what drug can cause this malignant hypothermia, without mentioning malignant hypothermia. So diagnosis is malignant hypothermia, and now what drug is causing it? So malignant hypothermia, or MH, I am writing for malignant hypothermia. This is a pharmacogenetic disease. Pharmacogenetic disease. That is, it needs interaction of some drugs with gene. So what are the drugs which can trigger this gene? So triggering agent. This is a favorite question of malignant hypothermia, drugs which trigger malignant hypothermia. So there are three drugs which can trigger malignant hypothermia. Number one, your succinylcholine, a depolarizing neuromuscular blocker. Then potent inhalational agents like halothane, your isoflurane, your sevoflurane. All this can trigger malignant hypothermia, but not the carrier gas, not xenon, not nitrous oxide. And sometimes lignocaine has been implicated to cause malignant hypothermia. So as I said, halothane, isoflurane, sevoflurane, desflurane, all this can trigger malignant hypothermia. So what are the drugs which trigger malignant hypothermia in the option? What is given? Which drug? Halothane is the answer. Remember, halothane can trigger malignant hypothermia. Propofol is an IV anesthetic agent. It is safe in malignant hypothermia. Nitrous oxide, the carrier gas, it is safe in malignant hypothermia. Etomitate is an IV agent. It is safe in malignant hypothermia. The potent inhalational can trigger malignant hypothermia. Remember this. The potent inhalational can trigger malignant hypothermia. Okay? So these three are the triggering agent. Now, what is the drug of choice for treating malignant hypothermia? Drug of choice for treating malignant hypothermia. Dantrolene. Now, dantrolene is a central muscle relaxant which stops malignant hypothermia. So, it's drug of choice. How do we manage if we suspect malignant hypothermia? We stop the triggering agent. We stop the trigger. We give dantrolene and we do a symptomatic management. So, this is the management of malignant hypothermia. Now, if a patient has malignant hypothermic gene, these triggering agents should be avoided. And as you can see, these are the agents which used for anesthesia. So in the patient with malignant hyperthermic gene, the IV anesthetic agents are safe. Propofol would be the agent of choice for anesthesia. Remember, for patient with malignant hyperthermic gene. Okay. Next question. In the capnography image, what does phase 3 represent? They have made an arrow over the phase 3. So this is phase 1, this is phase 2, and this is phase 3, and this is phase 4. There are 4 phases of a capnography graph. So this is again a very expected question. So many times I have taught you in the classes. Capnography. Now capnography is a graph of expired CO2 versus time. And in this we see 2 things, the graph and we see a numerical value. So how do we get this graph? As I said, capnography is expired carbon dioxide against time graph. So we need to connect the device between endotracheal tube and the circuit. So device is connected between the two, and the device has ability to ability to detect carbon dioxide. So what happens during respiratory cycle? Patient would be in inspiratory and expiratory phase. During inspiration, the inhalational anesthetic agent and oxygen will go from circuit into the airway. They do not have any carbon dioxide. So during inspiration, the graph of the CO2 against time would be 0. So it would be touching the baseline. There would be no CO2 in the inspiratory gas. When expiration happens, the expiratory gases from tube would enter the capno and enter the circuit. And when we expire, the first gas which we expire is dead space gas. Dead space gas has the same let's say gases present in it as inspiratory gas. It has no carbon dioxide because still in dead space O2-CO2 exchange does not happen. The first gas which will come out is dead space, and this doesn't have CO2. So dead space gas again would be flat, no CO2 would be detected. Then in dead space the alveolar gas will mix. So sudden increase in CO2 will be seen. Then only alveolar gas, dead space gas all expired out. So a plateau phase will be achieved. Now here the expiration is finished, inspiration will start, and again it will touch the baseline during inspiration. Again expiration, dead space plus alveolar, only dead space. Again it will touch the baseline. Remember, this graph has been given 4 phases, phase 1, phase 2, phase 3 and phase 4. Phase 1 represents the dead space ventilation. Phase 2, dead space plus alveolar. Phase 3, only alveolar. And phase 4 is inspiration. So here they have marked on phase 3, which is alveolar plateau phase. Remember, dead space is phase 1. The alveolar plateau phase is phase 3. The inspiratory is phase 4. And expiration of alveolar plus dead space air is phase 2. Okay, so simple question. One more thing very important we see in the capnography graph is the value, the numerical value, which is the end tidal CO2 value. The normal being between 35 to 45 mm of Hg. So we see the end tidal CO2 numerical value and the shape of graph, which has phase 1, phase 2, phase 3 and phase 4. Okay. Now next question. The relieving pressure of the pressure release valve of the following device. So first we need to identify the device. This is a bag valve mask popularly made by the Ambu company. So a lot of people know it by the name Ambu bag. Now Ambu bag is a device which we use for mechanical ventilation, for giving oxygen to the patient. It has 3 main components as the name suggests. Bag, it has a self-inflating bag, valve, it has a unidirectional valve and a mask by which we create a seal. So when we compress the bag, the room air or air plus oxygen mixture through this valve goes to the patient and patient receive positive pressure. Now number of times lot of high pressure can be created in this bag valve mask device which can cause barotrauma. So a relief valve has been provided. a pop-off valve or a pressure relief valve has been provided. So at what pressure this relief valve will open and will cause the release of pressure to prevent any barotrauma to happen. That would be 30 to 40 centimeter of water. So this is the answer, 30 to 40 centimeter of water. So remember, this bag, valve and mask, right? Bag, valve, mask. This has, most important, self-inflating bag. Now this bag, depending upon we are using for adult, pediatric or neonate, capacity 2 liter, 1.5 liter or 500 milliliter, it comes in different capacity. Then it has a valve which creates unidirectional flow of gas from bag to patient. And then it has a mask which create a seal over the patient. Then it has a pressure relief valve, which opens at the pressure of 30 to 40 centimeter of water, and it has inlet from which the oxygen and the air will come into the bag. So this is the inlet. We can attach supply of oxygen to it, or we can simply give room air to the patient. So it can give from 21 to 100% of oxygen, right? It can give 21 to 100% of oxygen. So this is bag, valve, mask. Coming on the next question. What is the use of application of PEEP? So a very simple question. So many times I have taught you PEEP. PEEP stands for positive end expiratory pressure, right? PEEP stands for positive end expiratory pressure. Now, why do we apply PEEP? What is the use of this PEEP? Now, PEEP is that pressure above which inspiration and expiration happens in a patient on mechanical ventilation. Our PEEP is FRC, functional residual capacity. In the patient on ventilator, we apply a positive end expiratory pressure and increase their FRC. Why? To prevent the collapse of the alveoli and to increase the surface area of alveoli for O2-CO2 exchange. So when we apply PEEP, what happens? The alveolar collapse is prevented. So it prevents atelectasis and it improves oxygenation. So PEEP is improving oxygenation, right? Whenever patient has a low PaO2 decreases. There are two ways by which we can improve it: by applying PEEP and by increasing FiO2. So by increasing PEEP and increasing FiO2, we can increase PaO2 of a patient. So what we do? We titrate at minimum PEEP and minimum FiO2, just adequate oxygenation. Whenever we apply PEEP, it has some side effects also. So remember, PEEP, when we are applying, the intrathoracic pressure can increase, and whenever intrathoracic pressure increases, venous return decreases. Whenever venous return decreases, cardiac output decreases. Whenever cardiac output decreases, the blood pressure can decrease and perfusion of the organs can decrease, and even barotrauma can happen because of increased intrathoracic pressure. So we have to be very careful in selecting PEEP. So what is the use of application of PEEP? To prevent atelectasis and improve oxygenation. It increases cardiac output? No, it decreases cardiac output. It increases venous return? No, it decreases venous return. So answer is to prevent atelectasis. Okay. Now coming on next question. Which statement is untrue about Emla cream? So it is a local anesthetic preparation which we use for topical anesthesia. So what is this Emla? Now Emla stands for eutetic mixture of local anesthetic. Eutetic means easily melted. So Emla is mixture of 2La, lignocaine plus prilocaine in 1:1 ratio. And the melting point of the Emla cream is lesser than ligno and prilo individually. So that is why it is eutetic. Eutetic means easily melted. Okay. We apply it on the skin surface, leave it for some time and then come back and do the procedure because it penetrates the skin surface since it easily melts and produce a surface anesthesia of 2 to 4 mm depth. Okay. So let us see the options. Emla stands for equal mixture of two local anesthetic. Well, it has equal mixture, but doesn't stand for equal mixture of two local anesthetic. It stands for eutectic mixture of local anesthetic. So this is an untrue statement. So this is wrong option. It is mixture of ligno and prilo? Yes. Methemoglobinemia can be associated with it. Prilo is associated with methemoglobinemia. So Emla can also be associated with methemoglobinemia. It can be used for venous cannulation in pediatric. Yes, it's most common indication of using Emla cream. So Emla, as I said, eutectic mixture of local anesthetic. In this we mix 5% ligno with 5% prilo. So now in Emla we have 1:1 ligno and prilo in 2.5% each. The concentration will be hard because they are mixed in equal amount. We apply it on skin surface, leave it for minimum 60 minutes, then come back and do the procedure. Now coming on contraindication of Emla, where we cannot put Emla. We cannot use it in neonate. Pediatric, we very commonly use it, but not in neonate. We cannot use if there is any breach in skin continuity. If there is any breach in skin continuity, we do not use. And we do not use it on mucous membrane. So we do not use it on mucous membrane. So these are three absolute contraindication of Emla cream. Okay. Now next question. Again a question on CPR. An unconscious child with no pulse and following ECG. No pulse means cardiac arrest, and this is the ECG we saw on the monitor. This is ventricular tachycardia. Ventricular tachycardia without pulse. So pulseless ventricular tachycardia. So immediately we have to defibrillate. That is, defibrillation is the immediate next management, and we start CPR. Minimum time between the pulselessness and defibrillation gives best chance for the survival. So defibrillation should be the answer. Just keep this chart in mind. When we evaluate the patient in cardiac arrest, 4 rhythm is possible. Ventricular fibrillation, ventricular tachycardia, both of these are shockable rhythm. Asystole and pulseless electrical activity, both are non-shockable rhythm. So in case of ventricular fibrillation and ventricular tachycardia, the immediate management is shock, right? And then we do CPR, take IV IO-axis, give shock again if 2 minutes have elapsed, and start giving doing CPR and giving our emergency drugs. This is how we manage the shockable rhythm. Shock, CPR, emergency drug. Shock, CPR, emergency drug. That's how we manage it. If it's non-shockable rhythm as asystole and pulseless electrical activity, we just do CPR and give emergency drug and nothing else. So if the same question which is given, instead of this ECG, if it was a straight line or not VFVT, not a straight line but some other electrical activity, that answer would be we do just CPR. Got it? That is pulseless electrical activity, or asystole, just CPR. VFVT, we give defibrillation. Got it? Okay, next question. Identify, again an image based question. Identify this image. Well, this is a nasopharyngeal airway. So many times I have showed you. Nasopharyngeal airway is a basic airway adjunct which we put from nose, remains in the pharynx, create an artificial passage for the air to pass. It has a beveled end like ET tube, but it is not marked like ET tube and it remains above the glottic opening. It does not cross the glottic opening. So it is nasopharyngeal airway, right? Its end is like ET tube, but it is nasopharyngeal airway. So let me show you images of other 3 options which was given. Other option was uncuffed ET tube. Uncuffed ET tube would also look like that, but it will have markings on it and size would be written and there would be a universal connector attached to it. So this is uncuffed ET tube. Then oropharyngeal airway made up of plastic, rigid plastic. This is the oropharyngeal airway, curved. And this is the Riles tube, which you have so many times used. Got it? So that was nasopharyngeal airway. Okay, next question. Which of the following procedure will become difficult if the patient has a deviated trachea? So patient has a deviated trachea. What procedure would be difficult? If someone has a deviated trachea, well, the pathology is below the glottic opening. So the procedures which we do for above glottic opening, that would not cause any problem, issues. So supraglottic airway insertion, we don't have, let's say we don't need any view for supraglottic airway insertion. We just need to have a good mouth opening, adequate neck movement, no neck pathology for supraglottic airway device insertion. So it would not be difficult. Then indirect laryngoscopy, not difficult. In case of deviated trachea. Intubation, well, moderately till moderately deviated trachea, if we are seeing the glottic opening, we can negotiate the tube through it, right? So maybe little difficult, but not that difficult. But tracheostomy certainly will become difficult, because if trachea is deviated from midline, other vascular structure will come in midline and make the tracheostomy real difficult. And in grossly deviated trachea, tracheostomy is even more difficult. So I would go for tracheostomy as the answer. Remember that the problem is below glottic opening, and tracheostomy we are doing below glottic opening. The intubation, of course, the tube is going below glottic opening, but we just have to see the glottic opening, do laryngoscopy, see glottic opening and insert the tube. We can negotiate the tube through it, okay? But definitely the tracheostomy in case of deviated trachea would become difficult. So answer is tracheostomy. So these were the important questions which were there, right? So let us repeat all the answers of the question. So which of the following process would become difficult in patient with deviated trachea? Tracheostomy. Next question, image-based question. Identify the device given in the image. Nasopharyngeal airway. Then unconscious child with no pulse. ECG, following ECG, what we will do? Defibrillation, because it is pulseless ventricular tachycardia. Then which statement is untrue about Emla cream? Emla stands for equal mixture of local anesthetic. This is wrong. It is eutetic mixture. Okay, next. What is the use of application of PEEP? PEEP prevents atelectasis. Next. Relieving pressure of pressure release valve in following device. 30 to 40 centimeter of water. Next. In capnography image, what does phase 3 represent? It represents alveolar plateau phase. Next. A 20-year-old patient undergoing strabismus surgery, the hypercarbia, hypothermia and muscle rigidity resulted. What drug may be responsible? Halothane, because it is mostly malignant hypothermia. Identify the image. It is Byers block. And the last question, during resuscitation, an unresponsive patient is kept in following recovery position. This indicates patient has pulse and breathing both. Then only we have made the patient in recovery position. So these were the 9 questions which I got. Any other question, please contribute in the chat box. I would add it in the discussion as well. Best of luck for your result. I know you will get a great rank.